안녕하세요. 삼성서울병원 치주과에 있는 양승민입니다.
Greetings, I'm Dr. Yang Seung-min of Periodontal Department at Samsung Seoul Hospital. Today I'm going to talk about what GBR is and how to do it. The contents of the day include overview of GBR, procedures of GBR, and take-home message. There are many different organizations. There are different groups as well. If you take a look, Lani Glossary of Oral Maxillofacial Implants was introduced in 2007. This was not done by an individual, but it was a collaboration between many different organizations. Let's look at the definition of GBR. GBR follows the principles of maintaining a surgically created space at a bony defect via a barrier membrane, thus excluding rapidly proliferating epithelial cells and fibroblasts and permitting the growth of slower growing bone cells and blood vessels. There's a bit of typo here. This is the definition of GBR. What is most important is membrane. There's something more here. It also talks about graft materials. The existing definition of guided bone regeneration only discussed about membrane. However, this definition also includes the definition about the bone graft material. If you take a look, it says that graft materials may also be used in combination with barrier membrane and GBR procedures to support the membrane and prevent its collapse. In addition, bone grafts provide a scaffold upon which new bone formation can occur. By GBR, membrane and bone graft materials are used to create space to allow new bone formation. It is a series of steps to achieve this. In the beginning, we only talked about membranes, but now the new definition also includes graft material in addition to membranes. This is a procedure that involves both membranes and graft materials. Why do we do GBR? After extraction, alveolar bone resorption occurs. As shown on this image, in the posterior area, resorption can occur in this direction. It goes up and towards the inner side. In the lower, it goes down like this. If we place the implant in the ridge shape like this, then the prosthesis would go on top like this. The occlusal relations will be inappropriate. In order to do restoration-driven implant placement and have ideal occlusal relation, we need to place implant here. However, in that case, inevitably, there will be lack of bone height and width. We need to have understanding of this. Rather than the existing bone structure, in order to form ideal occlusal relation, we need to make up for the insufficient bone to place implant in an ideal manner. If we do this, it will be much more favorable in terms of form and function. Rather than just placing implants, we need to understand what the future prosthesis is going to look like and determine implant position. And that is why GBR is necessary. In order to do GBR or form new bone, what is important? The three factors are important. First, preservation of blood clot. Second, osteoblast should be formed. Third, this is mentioned very frequently, but the space maintenance is really important. Certain membrane has been used to secure space, and this membrane needs to be maintained until osteoblast cells can fill in. The importance of membrane cannot be overemphasized. I've already talked about it when we talked about GBR definition, but bone graft materials can be used together. Bone graft materials support the membrane and help in space maintenance. Therefore, use of graft material is important. Blood clots and osteoblasts are maintained within the space, so it is very important to know that the membrane along with bone graft material play a very important role here. Bone graft material, membrane, they need to be in balance in order for us to be able to get the good results. To do successful GBR, what kind of principles do we need to abide by? We need to stick with PASS. The name PASS came from the first alphabet letter of each factor. This person suggested it. It's very easy to understand, so I referenced it. P came from primary wound closure. A from angiogenesis. We need to secure channel for angiogenesis. Also, S is from space maintenance. We need to use membrane to secure space. What is largely overlooked is the stability of wound and implant. By stability, not only do we need to think about the defect, but we also need to think about the stability of membrane and bone graft materials. The PASS principle includes all four factors: primary wound closure, stability, and space maintenance using membranes and angiogenesis. If we can secure all these four factors, then we'll be able to get good results. How should we perform GBR in order to get good results? Let's look at it briefly. As a joke, I say you open the door and close the door to put the elephant in the fridge. If you look at the order, you make incision, reflective flap, check the defect, and then place the implant. You use membrane and bone graft materials and apply it there, and after that you do suture and close the case. If you look deeper into different steps, it gets more complicated, but you need to have this big picture in mind as we perform GBR. In order to regenerate the bone, what is required? As mentioned earlier, we need to take note of PASS principle. Let's take a deeper look. Blood supply is very important. Wound and membrane stabilization is very important as well. Osteoblasts need to exist. I've also accentuated the importance of space maintenance. Primary closure. These 6 factors need to be taken note of. In addition to PASS principle, we also need to consider cortical bone and what kind of tools we're going to use for fixation, such as use of pin or screw. Some people think only 4 factors are important, whereas others believe 3 are sufficient. There may be varying opinions, but we need to stick by the basic PASS principle. This is a live surgery case done by another dentist who also participated in the same seminar as I did. This kind of patient came in. You can see that the healing is not done properly. I think there's going to be a bit of defect. If you make incision, you make vertical and horizontal incisions. That being said, what kind of horizontal incision are you going to make? In general, you can choose between crestal and paracrestal incision. That is a decision you need to make, and you need to have evidence to support that decision. Where are you going to make a vertical incision? This is another important thing. You need to think about these factors before making incision, and you need to have proper understanding in order to make a proper incision. How to make incision? You need to make minimal damage. If there is damage to the tissue, it will become difficult to abide by the past principle which was addressed earlier. Attention should be paid to minimize damage. In talking about crestal incision, the amount of keratinized gingiva remaining on the buccal and lingual side should be more than 2 millimeters. What would happen if there is insufficient keratinized tissue? At times, it will be difficult to secure 2 millimeters. Depending on surgeon, you may widen the keratinized gingival zone. If there is a severe lackage of it, after surgery, additional procedures can be taken to restore the amount of keratinized tissue. We also need to consider blood supply. When doing this, the incision needs to be made towards where the base is wide. Another point is that you should not make excessive releasing incision. Avoid releasing incisions in the vestibulum. As mentioned earlier, trapezoidal flaps with anterior and posterior releasing incisions for the coverage of augmented sites is necessary. We do not make such releasing incisions every time, but depending on the amount of augmentation, you can do it. If you have made appropriate incision, now you need to open flap. Full thickness flap should be reflected in principle. How do we do this? You need to expose the surgical site completely. If you reflect the flap only a little bit, there can be areas where we miss something. In the area where there is concavity, we can miss things, so we need to open full thickness flap, and then we need to check the bone defect. We need to look at the contour of the defect. We need to make a decision as to where the implant is going to be placed, and we need to think of how the bone defect will be following that. In line with such considerations, how to do GBR can be determined. You can see that implant has been placed, and cover screw has been connected. We need to decide how much area we're going to cover. We're going to make a decision as to whether we're going to use cover screw or a special tool, or are we going to cover the entire area. We need to determine the amount of bone regeneration that can be achieved based on the defect. Many things change depending on the amount. If you take a look, there is a cover screw dedicated for GBR. It's unlike the general cover screw. The cover screw for GBR has 0.6 millimeter of height. You can make it in line with a crest, or like this. Up to this point, the bone graft can be filled. You can do it like this. You can use a general cover screw, yes, but these tools are available. If you know about these, then this can be of help. After implant placement, as mentioned earlier, we need to consider angiogenesis and the past principle. We need to get a blood source. If the cortical bone is very thick, then we need to do a bit of perforation like this. This is to provide blood supply to the surgical site. There's controversy as to whether this is appropriate. Some people argue that bone formation can be done nicely even without perforation. On the other hand, some people argue that there needs to be sufficient blood supply for sufficient bone formation in the early and middle stages, and some people find it more stable. There's no definite answer as to what is right. This is really up to your preference. You can really tell the difference in terms of stability when you compare between mixing bone graft materials with saline and mixing bone graft materials with blood. I'm sure you'll be able to get a sense of which is better in terms of manageability when mixing bone graft material with something and doing without. In that sense, if the clinical situation is not unfavorable, a perforation may be a good choice. Then you do bone graft accordingly. You can see if bone graft has been applied here. How much bone graft do you think should we apply? And how should it be applied? This is the question that comes to mind. How much and how to apply them? First, we need to look at the bone defect. When there is a bone defect of type 2, type 3, and type 4, the bone graft needs to be maintained within the space that we make. Just because we apply them does not mean that they're going to stay the same. There's going to be shrinkage and resorption. If the amount of bone augmentation is shown in blue, we need to do overfilling by about 1 millimeter. We need to do overfilling on the lateral side and on top. So about 2 millimeters of overfilling is required. How should it be applied? It's not to say we should pack in the bone graft materials, but we need to make sure that there's no empty space in the bone defect area. In order to do this, as mentioned earlier, you can apply saline or blood, and when you do hydration on it, it's going to be easier to manage. If there's perforation as shown, there's going to be a bit of bleeding. You can do sufficient hydration utilizing that. After bone graft application, you have to apply the membrane. You can choose resorbable, non-resorbable membranes. The criteria in terms of how to choose between the two options is explained in a different lecture. You need to determine whether you're going to use a resorbable or non-resorbable and whether you're going to fixate the membrane or not. In general, on the graft material, membrane is applied and you need to abide by this principle shown in this image. Bone graft material should be added 1 to 2 millimeter more on the bony defect. The more you apply, it's actually better. You need to cover the defect area widely. It needs to be 2 millimeters away from the flap margin, and this is when we're talking about non-resorbable membrane. As for 1 millimeter, it's for resorbable membrane. Whether we're going to fixate the membrane or not, in terms of that consideration, we do not use a special tool or suture, but you can see that 3 to 4 millimeter of the inner surface of the flap is engaged to get a bit of fixation from the lingual flap. If that is insufficient, you can utilize suture. If even that is insufficient, you can use special tools like a bone tack or bone screw to fixate the membrane. If you do this, then you can reduce mobility of graft even if it is just a little bit. Before suture, when we have grafted the defect and applied the membrane on top of it, in order to get the primary closure, releasing incision is made. As shown, releasing incision is made below the mucogingival junction. You can make it once or twice. To get the desired primary closure, you can utilize different methods. You need to pull the flap margin without tension to cover the membrane. In order to get primary closure, different methods can be utilized. The type of suture method does not matter. As mentioned, we need to pull the flap margin without tension. If we are to get a tension-free primary closure, it doesn't matter what kind of suture you use. If you look at the sutures that are used frequently, it includes interrupted suture, horizontal mattress suture, and crisscross suture. Regardless of which you use, it's not going to be a problem. We have looked at the overview of guided bone regeneration and how to do it. If you have accurate understanding of GBR, then you would understand the importance of membrane and bone graft materials. Utilizing these, there are preconditions that need to be satisfied in order to get successful GBR. As mentioned earlier, you need to have a clear understanding of GBR procedure to be able to do successful GBR. Albeit in a short time frame, I've talked about GBR. Guided bone regeneration is applied in almost all implant treatment cases. This is an essential procedure. In order for you to be able to do successful GBR, you not only need to have the knowledge, but you also need to do hands-on practice. Today, we've only had a short time frame, but if you come to offline lecture, we will be able to focus more on what is important in reality and narrow down on key aspects. I hope to share with you clinical tips and know-how. Thank you for your attention.